Ganesh Rai. So, sir, am I audible to you?
Yeah.
Okay, sir. So, this is a 2 years, 10-month-old male child brought to your OPD for complaints of dry cough and noisy breathing for last 7 days. He has had two similar episodes this winter. Each episode starts with runny nose, cough, and mild fever, and which gradually progresses into wheezy chest in 3 to 4 days. And every time he visits his local pediatrician, he is prescribed oral salbutamol, antihistamine like fexofenadine, antibiotic like cefixime, and paracetamol. But in between episodes, the child is very fine. He has no symptoms. So there is no family history of allergies or personal history of atopic dermatitis or food allergies. There are no pets at home. But the significant history is grandfather who lives together is a smoker. For clinical findings, the child looks alert, cooperative, weight and height are normal for age, vitals are within normal limit. Throat examination shows mild congestion, and in chest auscultation there are occasional wheezes. So with this history, sir, can we have some provisional diagnosis?
I think this is the simplest case so far we are presenting. And the diagnosis is very straightforward here. I would say it's a viral induced wheeze or episodic wheeze caused by viral infection, upper respiratory tract viral infection. And I nothing comes in mind except that, because the child vitals are normal. The child has had only noisy breathing and dry cough, no dyspnea, no fast breathing. But this child does have wheezes. Only the throat is congested. Therefore, it's a episodic wheeze.
Okay, sir. So there are no other differential diagnoses?
Not much.
Okay, sir. So we are not thinking about pneumonia in this case?
Yeah, no, because the fever is, the child doesn't have fever. Although there is a history of 3, this is the third episode, and this time the child doesn't have fever.
Okay, sir. So any investigations you would like to do in this child?
At the moment, even I don't go for any investigation. But as this is the third episode, if somebody asks me, or if the parents are, let's say, very anxious, then we can tell whether, and somebody asks me whether this child is going to develop asthma. In such case, then we can use so-called asthma predictive index, and this index is also this child, I can say, is not going to develop asthma because there is no history of parental asthma. The child doesn't have atopic dermatitis or eczema, and these are the major criteria. And minor criteria like there is no allergic rhinitis. This running nose is because of viral infection, I think. And also, the wheeze is occurring only during the viral infection. And about the eosinophils count. In our part of the world, mild eosinophilia you may get because of helminthic infestation. Therefore, I don't think this child is going to develop asthma, and we can go for so-called modified asthma predictive index like skin allergic sensitization test. Again, this is not indicated at the moment, and there is no, as you mentioned, there is no food allergy. Therefore, at the moment, I'm not going to do any investigation for this child. If later comes with repeated attacks, more severe attacks, then we may need some investigation.
Okay, sir. So some recent research articles say that, as you have said, we have ruled out atopy in this child. There is no personal history and no family history of atopy. But what about the non-atopic, non-IG mediated asthma? Can we think about that in this child?
Because of the symptom, because of the severity of the symptom, although it's a third attack, I don't think so. Maybe our other panelists, they have their different opinion.
Okay, so any other panelist, can we think of a neutrophilic asthma in this case?
Right. So neutrophilic asthma is basically when you have poor response to your treatment and we are going for the bronchoscopy and you find neutrophils in the bowel or in the biopsy specimen, at this stage, I think this neutrophilic or eosinophilic or mixed type of categorization will be very difficult and probably not required also. What at the most we can say that whether this child will have asthma or not will depend upon the other underlying feature which Rai sir has already told us. So it doesn't fit at all into the asthma diagnosis at first place. So I don't think the neutrophilic question arises at the second place.
Okay, because nowadays there is the concept that in less than 5 years, there is more prevalence of neutrophilic inflammation of the airways rather than IgE mediated or eosinophil mediated inflammation. So Dr. Amrit, any comment on that?
No, in this case, I think I would like to go with common diagnosis, think of the common cause, and maybe I don't think neutrophilic
this neutrophilic response occurs even in case of viral infection.
Yes.
Even in the RSV infection, if you do the bowel, you will get the neutrophilic. It doesn't mean that
yes,
you have this.
And in the bowel report, the differential may not be very concluding. So I don't go with the neutrophilic asthma with this, and I would like to think of the common cause, manage common things first. If it does not respond, then only I would think of other things. And before thinking of neutrophilic asthma, I would like to put common childhood asthma as a provisional if the child does not improve.
Okay, thank you. So for treatment, right, sir, what would you give for this child?
Let me discuss the treatment the child is on. And I'll try to be very quick because of the time factor. The child is on oral salbutamol. Now, I would like to compare the effect of oral and nebulization or inhaler therapy. If we give orally, this has got more systemic side effects, and the action is very, very slow. As Dr. Deepak already said, that's why we have to try to avoid the using oral salbutamol. I go for MDI with spacer, MDI salbutamol inhalation with spacer and face masks, and it has got quick action, less side effect, but in our society, because if we prescribe inhalers or less, they think that the child will get addicted, and we have to counsel the parents regarding the addiction, and therefore I go for MDI with spacer and face masks for broncho obstruction. And the second one, the child is on fexofenadine. The child doesn't have any manifestation of allergy. Therefore, this child doesn't need fexofenadine. And the third one, antibiotics. This time, the child doesn't have fever. The child is not dyspneic. The child respiratory rate is normal. There is only occasional wheezes and only cough. Therefore, first we have to decide whether antibiotics is indicated or not. Then if indicated, which antibiotic will be the best one, right? Therefore, in this case, at the moment, I don't think there is indication for antibiotic. Let's say if we think of using antibiotics, they have used third generation oral cephalosporin. As far as respiratory infection is concerned, prodoxamine is better than cefixime. Cefixime is better for GI tract and UTI. Therefore, it's not very relevant. Now, for respiratory tract infection, what we usually use is amoxicillin. If it doesn't respond on amoxicillin, we go for amoxiclav. Now, we talked about neutrophilic inflammation, Neutrophilic, we never know. As far as I remember, perhaps about 20% of such cases may have neutrophilic inflammation. And in such case, microlides is the best. It has also got anti-inflammatory effect. Therefore, the antibiotic of choice would be, in my opinion, microlide, that is azithromycin. and paracetamol, the fever is not there. Therefore, this should be the plan of treatment management in this child. Now, I would like to highlight one thing here. There is some smoker in the family, and we all know smoking triggers viral infection as well as wheeze. Therefore, we have to try to avoid smoking in the family. And in counseling, it is said, we have to counsel not only the parents, we have to also counsel the grandparents. Usually our grandparents, they smoke. Therefore, counseling is a very important part here, and we have to counsel them to stop smoking.